move on. And the second indication where we found amniotic membrane very useful was in a pathology which is very difficult to treat, which is optic disc pit maculopathy, because it reacts in a very variable manner. So Dr. Gagan will take us through this topic.
Thank you, everyone, and I would like to thank again the AIOS Scientific Committee for this IC. And so amniotic membrane grafting and optic disc pit maculopathy. So basically, optic disc pits is a congenital abnormality which is rarely seen in almost 1 in 10,000 eyes, and probably happens because of improper closure of the optic fissure. It is optic disc maculopathy basically is a serous detachment of the macula and retinoschisis, which happens in almost 50% cases with optic disc pits, and if left untreated can really get the vision down. So this thing is very controversial as to where the fluid comes in from. There are various theories. Some say that it is through the vitreous, some say it is CSF, and some also postulate that the leaky blood vessels are the defect, which are there, though, and there are a mechanism of vitreous traction and pressure gradients within the eye which also contribute to this. So if you see the morphology of optic disc pit, the macular area would basically show a schisis of the inner layers, and then it can also show an outer macular hole and an outer retinal detachment on a neurosensory detachment. So as far as management is concerned, again, it is basically about drying the macula and decreasing the traction. So pars plana vitrectomy is the mainstay. Basically, that means inducing posterior hyaloid separation, and also has been juxtapapillary laser again to cause a barrage between the disc and the macular area, and optic neurotomy and inner retinal festration, which are not very famous. Then came the area where they started stuffing it. So basically, you do and induce a PVD, and then you stuff the hole so as to again cause a barrage. And the most studied ones are ILM and newly now as Sclera, which has been used. And we'll be talking about amniotic membrane grafting. So AMG grafting for disc pits was first popularized by Dr. Rizzo and his team with 3 patients of 3 eyes, and he presented his 6 months follow-up in retina. And that is what inspired us to go ahead and start using these membrane grafts in our patients. So this has already been covered by Dr. Darius. We again use the same technique to kind of size them and stain them. So after inducing a PVD in a case of disc pit, we go ahead with the core vitrectomy and also do a base shave as much as possible. The ILM is stained, and after staining, it is very imperative that you do a very careful ILM peeling in these cases, because you don't want to create a macular hole, and also do a maculosparing peel. There is always a lot of fluid under it, and there is schisis, and the retina is pretty thin. So after we do a ILM peel, and always leave, in our technique, we leave a little scuff at the disc margin. This is covered by Dr. Darius. We stain the graft so in these cases of disc pits, we measure the maximum linear diameter, and then a trephine is used to take the graft. Again, 23 gauge sclerotomies are the best to use because they go through well, and they don't crush the graft, or the graft doesn't get stuck. Again, bimanual technique to kind of release the graft from the fossa, but you'd see that it is a bit difficult to do that. And then finally, it is placed in the disc pit area by manually using a nitinol loop and a blunt Tano scraper. Would not advise using a forceps because it can sometimes can lead to a peripapillary damage. Then the cuff of ILM, which is left behind, we just kind of peel it as a disc-based flap, and just to keep the ILM in place. At that point, we complete the ILM peeling, a maculosparing peeling, and then finally do a gas exchange. So we kind of collated our data and present this 5 eyes at present, and there was a female preponderance, and the mean age was around 30 years, with left eye being more prevalent. The mean horizontal diameter of these pits was roughly around 784 microns, and duration of around 5 months, plus minus 10 months. And retinoschisis and SRF, as the stages goes, were present in almost all eyes. So the visual acuity gain was significant from 1 logmar to almost 0.5 logmar, and there was a drastic reduction of the central macular thickness from almost 900 microns to 198 microns, and most of the cases basically showed a rapid reduction in fluid ranging between 2 to 4 months. So this is the first case which I'm showing. This was the first case which we had done, and this was of a pediatric girl who presented with a disc pit, and the visual acuity was roughly around 6 to 20 by 80, and the linear diameter was again 926 microns. We used a 1 mm Refine to do this, and if you see over 3 months period, there was absolute flattening of the macula, and there was no fluid present, and the vision almost improved to 6 by 9. And over 3 years now, it's around 6 by 6. So this is the second case. Again, why I included this case is because this is a recurrent pit. So this lady, again, she had a juxtapapillary laser elsewhere, which was the norm when she was probably 13 or 14 years old. And then she presented to me somewhere around 4 or 5 years ago, 3 to 4 years ago, when she had this recurrence. We followed her up because it is important to realize that don't go into these cases immediately, because sometimes they do maintain very good vision. They have a waxing waning kind of a period, and only when she had this drop in vision to 6 by 36, we went ahead and did the procedure. So with gas in situ on day 2, you see a rapid flattening of the fovea. And if you see the AMG is still in situ at 2 months, so this is a pointer for Dr. Roshar and Dr. Darius and Dr. Dipinder. And there was reduction in the NSD as well as the schisis. Over 8-month period, you can again, if you see the top left hand corner image and also the OCT scan, the AMG is still in situ and it's not absorbed. And the foveal contour is well maintained. There is no NSD and vision improved to 6 by 12. This third case, the reason for including this case for presentation today is because I remember when I had presented my first case, which was a solitary case at a meeting, I was basically asked, I was given a comment that, don't you think that you're just lucky? So that is because, ILM peeling and PVD induction were the mainstay of treatment even before. And I see Dr. Charu also here laughing because he also believes in that. But so the reason for including this case is because, yes, AMG does make a very big difference. So in this case of a 15-year-old male, again, we saw that this case had everything. It had an NSD, it has an itomacular hole and schisis. So we went inside, we did a AMG. The AMG is still in situ, but if you actually see the cut, it is kind of, as the gas is reducing, the AMG is also flowing away. So, and surprisingly, at 8 weeks, when the gas went away, if you see where the AMG is gone, it's gone to the nasal side and the fluid has come back. So I think this case was included basically to show that AMG, yes, definitely plays a very important role in addition to the macular-sparing peel and PVD induction in these cases. So in a follow-up, mean follow-up of around 11 months, the visual acuity is around 0.5 logmar with a CMT reduction of 128. The NSD resolved in almost 60% of eyes. This is, and schisis in almost 40%, and the AMG was in situ in 80% of eyes. Because this data is only of 5 patients, so obviously the percentage difference is large. But if we compare it to, again, back to Dr. Rizzo and Caprosi, their team, they also presented their data with 11 eyes, which was a 1-year follow-up, almost similar to our last follow-up of 11 months. And in their case also, if you see that the reduction in CMT is almost the same as our study, and the visual acuity improvement also seems to be almost same. And there was complete resolution again in 9 of 11 eyes, where in our eyes also there was, because the graft went away, there was lesser resolution in that patient. So I believe that, to conclude that human amniotic membrane grafting definitely is helping in these cases in macular holes as well as in optic disc pit. And yes, a larger comparative series is definitely required to establish the role further. Thank you.
Thank you, Dr. Gagan. So do you think you are doing it in primary cases, and should amniotic be used in all pit cases, or would you first like to do the ILM?
So I would like to put it this way, that I would not want to intervene in an eye which has very good vision. That is number one. And secondly, as of today, looking at this data, I think I would definitely keep AMG as the first choice in my armamentarium for sure. Yeah, because it's not like ILM stuffing doesn't work. There's a huge amount of data and work on ILM stuffing as well. But then that ILM stuffing sometimes does tend to go away. And those short series, but AMG, definitely is staying there, which is very contradictory to what Dr. Rushad and Dr. Dipinder were pointing out to. So probably again, the one point which I picked up, and maybe I'll go back and literature search this also, is that that probably it's some sort of a basement membrane that starts growing under, which gets the amniotic membrane to go away. And probably in our cases, because it's just a pure scaffold and there's nothing growing there, maybe it's not. And if you even, as I spoke about overlay techniques, that it starts, the epiretinal part starts to kind of go away. And as Dr. Carlos has also showed in his cases, it's the part which is in the macular area, inside the macular hole, which does not tend to go away. So probably it's something that stays for a longer time and probably would kind of suffice to us needs, especially in these cases.
And do you also drain the fluid from the pit?
No, we don't drain that fluid from the pit. None of these cases we actively drain the fluid.
What about other graft material like sclera? And I think Dr. Dipender was suggesting using tenons. I don't know what. It's not on mic.
Hello.
Yeah.
Any role of autologous blood over the pit or fibrin glue?
Yeah, so there are single case reports of autologous bloods as this thing, but then all those techniques have again used an ILM flap. So they probably just use the blood to secure the flap in place,
Yeah.
and not that they have primarily
Plugging.
been as like this thing. Of glue again will kind of go away, and so then again that will be temporary. So I think sclera is something that is again permanent, but again harvesting the sclera and then that is something little challenging because usually as retinal surgeons, yes, though we are kind of used to doing scleral buckles and doing a cut down, but I don't think I would want to make another hole in the eye which already has a hole inside.